There's a complication that surgical teams have quietly discussed among themselves for decades. Not the infection, not the blood clot, not the wound that takes longer than expected to close. The complication nobody warns you about is the anesthesia itself. And if you're over 70, or if someone you care deeply about is scheduled for a procedure in the coming weeks or months, what you are about to hear may be the most important thing you encounter before anyone in that family walks through the doors of an operating room. Because there's a question that almost no patient thinks to ask. A question that your surgical team may never raise on their own. And by the time you finish reading this, you will know exactly what that question is, how to bring it up in a way that gets taken seriously, and what 4 specific alternatives exist that could protect the most vital organ in your body. Not your heart, not your lungs, your brain. Most people, when they learn they need surgery, direct their energy toward one thing: the surgeon, the procedure, the success rate. They search the doctor's credentials. They read about recovery times. They think about the incision, the discomfort in the first few days, the weeks of rehabilitation ahead. And none of that is wrong. Those are entirely reasonable concerns, and I am not dismissing a single one of them. But here is what I have observed across 3 decades of clinical practice as an anesthesiologist. This shift in focus changes everything that follows. For a patient over 70, the surgery itself is very often not the greatest source of risk. The greatest risk, the one that tends to go unaddressed, is a specific type of anesthesia. General anesthesia. The kind that does not simply put you to sleep, but chemically suppresses your brain to a profound depth. A breathing tube is placed in your throat. A machine takes over respiration. The pharmacological activity across your entire central nervous system is deliberately and significantly reduced. For a healthy person in their 40s, the brain absorbs this and recovers. The body rebounds. Within days, they feel like themselves again. But for a person over 70, that same pharmacological suppression can set in motion a process that continues long after the surgical wound is healed. And most patients are never told this before they sign a consent form. So the question shifts. It is no longer only who is performing the surgery. The question that actually matters, the one that can determine what your life looks like 6 months from now, is this: how is my brain being protected during it? Let me explain why this matters at a biological level, because once you understand the mechanism, the concern becomes impossible to dismiss as overstated. The brain of a 70-year-old is not neurologically identical to the brain of a 40-year-old. This is not a statement about intelligence or capability. It is a statement about something researchers call cognitive reserve. Cognitive reserve is the brain's internal buffer, its capacity to absorb disruption and return cleanly to its previous baseline. Younger brains carry substantial reserve. Older brains carry less. The margin between disruption and lasting change is genuinely narrower. When general anesthesia is administered, the drugs involved, induction agents, muscle relaxants, volatile anesthetic gases, bind to receptors across the entire central nervous system. They do not produce a gentle drowsiness. They suppress the brain systematically, including the regions responsible for memory consolidation, spatial reasoning, and sustained attention. And in a patient over 70, the liver and kidneys process and eliminate these drugs more slowly than they would in a younger body, sometimes significantly more slowly. The drugs remain in the system longer than the dosing schedule technically accounts for. The exposure to the receptor sites is extended. The neurological recovery window stretches in ways that are not always predictable in advance. What tends to follow, in somewhere between 30 and 40% of patients over 70, is a condition that appears in the first 1 to 3 days after the operation. It is called postoperative delirium. And I want to describe what it actually looks like in a real person, because the clinical term sounds distant and manageable, and the reality is neither of those things. The patient wakes up not knowing where they are. They believe they are at home or somewhere from 30 years ago. They become agitated, or they become completely unreachable and still in a way that feels wrong to everyone around them. Sometimes they perceive things that are not in the room. Sometimes they do not recognize the faces of family members who are standing right beside them. A son I spoke with after his father's hip surgery described it this way. He said his father looked at him with recognition of the name when he said it out loud, but the eyes were somewhere else entirely. Like the man he knew was standing behind frosted glass. The family had expected grogginess, perhaps some confusion. They had not expected that, and they were not prepared for it. But here is the part that matters most, and the part that tends to be absent from preoperative conversations. Delirium is not reliably temporary. In a meaningful percentage of elderly patients, postoperative delirium is followed by something called postoperative cognitive dysfunction. The memory does not fully return to where it was. Processing speed remains slower. The sharpness that existed before surgery, the ability to recall names without searching, to follow a conversation without losing the thread, to track several things simultaneously, is reduced. Sometimes for weeks, sometimes for months. And in some patients, the evidence strongly suggests the reduction does not fully reverse. Think carefully about what this means in practical terms. This is a person who is driving independently before the operation, managing their own finances, living fully and on their own terms. And now family members are quietly reorganizing their schedules to help. Conversations are happening behind closed doors about what level of support is needed going forward. And the surgery that was supposed to improve quality of life has instead become a marker in time, the before and after point when everything shifted. This is not a theoretical concern. Research in this area has been accumulating steadily since the 1990s. Postoperative cognitive dysfunction in elderly patients is now one of the most actively investigated areas in all of anesthesiology, precisely because the population over 70 is growing rapidly and the stakes are rising year by year. Researchers continue to debate whether general anesthesia directly causes lasting cognitive change or whether it accelerates a neurological process that was already beginning at a very gradual pace. Honest practitioners acknowledge that the science is not yet fully settled. But what 30 years of clinical observation makes unmistakably clear is this. We consistently see better cognitive outcomes in elderly patients who receive regional anesthesia rather than general anesthesia. The difference is not marginal. It is clinically significant. It shows up in delirium rates, in length of hospital stay, in how quickly patients return to independent function, and in family assessments of cognitive baseline after discharge. That pattern is consistent enough that many of the leading surgical centers across the United Kingdom, Scandinavia, and major academic medical institutions throughout North America have made regional techniques their standard approach for elderly patients wherever it is medically feasible. Which raises an obvious question. If the evidence is this clear and the alternatives exist, why are so many patients over 70 still receiving general anesthesia? This is the point where many older patients hit a wall. They do their reading. They become genuinely concerned. They arrive at the preoperative consultation and raise the issue. They say something like, "I have read about cognitive risks with anesthesia in older patients. Is there another option?" And sometimes, not always, but often enough to be a recognizable pattern, the response they receive is, "This is our standard approach for this procedure," or "You will be completely safe, there is nothing to worry about," or simply, "This is how we do it." And the patient backs down. Because who are they to push back against the surgical team? But here is the problem with standard procedure. Standard protocol was designed around the average patient population. And the average patient population, weighted across all ages, is substantially younger than 70. When you're over 70, you are not in the average category for anesthetic risk. You are in a different physiological group with different drug clearance rates, different cerebrovascular reserve, different receptor sensitivity, and different cognitive vulnerability. Your anesthetic plan should reflect that individual reality rather than being designed for someone decades younger. General anesthesia is not always avoidable. For complex cardiac procedures, certain neurosurgical operations, lengthy abdominal surgeries with specific airway requirements, or emergency situations where time does not allow for a careful regional setup, it may be genuinely necessary. And when it is truly necessary, A skilled anesthesiologist will take every available step to protect the aging brain. Careful drug selection, minimizing total doses, using brain activity monitoring where appropriate, ensuring the fastest possible emergence from anesthesia, managing sedation in the recovery period to prevent oversuppression. All of that is real and meaningful. But general anesthesia is far more avoidable than most elderly patients are ever told. Because 4 specific regional techniques exist, each matched to a different type of surgery, each allowing a patient to undergo a major procedure without deep pharmacological suppression of the brain. And you deserve to know all 4 of them in enough detail to have a real conversation about them. The first, and the most transformative for surgery involving the limbs, is peripheral nerve block. The underlying concept is elegant in its simplicity. Pain signals from any surgical site travel through specific, named nerve pathways before they reach the brain. The shoulder, the knee, the hip, the hand, the foot, each region is served by identifiable nerve bundles that follow predictable anatomical routes. What if those signals were intercepted before they could travel at all? Using real-time ultrasound imaging that displays the precise location of the target nerve on a screen, a small quantity of local anesthetic is placed directly adjacent to that nerve bundle. The result is complete numbness throughout the entire surgical region, and only that region. Not the whole body, not the spinal cord, precisely and exclusively the operative site. The patient remains awake throughout or rests in very light, comfortable sedation. A gentle drowsiness, nothing approaching unconsciousness. The brain is not suppressed. There is no breathing tube, no ventilator, no systemic pharmacological shutdown. The patient breathes independently, maintains their own airway, and can speak and respond if needed. And the block continues providing pain coverage for 12 to 24 hours after the operation is finished. That first day of recovery, typically the most painful, is already managed by the local anesthetic that was placed before the first incision. The patient requires far less opioid pain medication afterward, which matters enormously, because opioids in elderly patients carry their own significant risks, including confusion, excessive sedation, balance problems, and falls. 4 hip replacements, knee replacements, shoulder repairs, and hand procedures. Peripheral nerve block is genuinely reshaping how thoughtful anesthesiologists approach care in older patients. The outcomes data continues to strengthen with each passing year. The second technique is epidural anesthesia, and this is the appropriate approach for larger operations involving the abdomen or the chest. A thin, flexible catheter, roughly the diameter of a strand of thick thread, is placed in the epidural space, the region just outside the membrane surrounding the spinal cord and the mid-back. Through this catheter, local anesthetic is delivered continuously throughout the entire operation, covering the surgical area with precision. The patient requires dramatically less general anesthetic agent. In many cases, the epidural provides sufficient coverage that the general anesthetic component is reduced to a minimum, just enough to ensure comfort and stillness, rather than the full pharmacological load that would otherwise be required. The brain is largely spared the deeper chemical suppression. The catheter remains in place for 2 to 3 days following the operation. Post-operative pain is managed continuously and precisely, using a fraction of the systemic drug doses that would otherwise be necessary. The patient moves earlier. Respiratory complications associated with undertreated pain are reduced. The entire recovery trajectory is measurably different and measurably better. The third technique is spinal anesthesia, which is distinct from epidural and is the preferred method for surgery of the lower body. Hip fractures, knee procedures, prostate and bladder operations, lower abdominal hernia repairs. A single carefully placed injection delivers local anesthetic into the cerebrospinal fluid in the lower lumbar region. The anesthetic spreads to a precisely controlled level, producing complete numbness from approximately the waist down. The effect typically lasts 2 to 4 hours, which covers the majority of lower body procedures comfortably. The patient may doze lightly, listen to music, or simply rest quietly. Some request mild sedation for comfort, but the brain is not chemically suppressed to the level of general anesthesia. The airway is maintained entirely by the patient. No tube, no ventilator, no forced shutdown of consciousness. For elderly patients with hip fractures in particular, spinal anesthesia has become the preferred standard in many of the most respected surgical centers worldwide. The data on delirium reduction compared to general anesthesia is consistent across different patient populations, different countries, and different healthcare systems. This is not a niche or experimental approach. It is the direction that evidence-based medicine is clearly and consistently moving. The fourth technique, and this one surprises many patients because they had not considered it a possibility, is conscious sedation combined with local anesthesia. This is the approach for smaller procedures. Cataract surgery, carpal tunnel release, minor hernia repairs, certain skin procedures, and biopsies. The patient receives carefully titrated sedation, producing a relaxed, calm state where anxiety is absent and comfort is complete, but where if someone speaks your name, you respond. You are aware at a gentle level. You are not unconscious. You're not intubated. Your brain is not carrying the full pharmacological burden of general anesthesia. The local anesthetic is placed directly at the surgical site, providing complete pain control for the procedure itself. For cataract surgery in particular, a procedure that takes well under 30 minutes in experienced hands, a significant number of elderly patients are still receiving general anesthesia purely out of departmental habit. Conscious sedation is entirely adequate, gentler on the aging brain, associated with faster recovery, and allows the patient to return home the same day, feeling nearly themselves within hours. The cognitive difference for the patient is not subtle. Now let me give you the specific language to use in your preoperative consultation, because knowing these four options is only half of what you need. The other half is knowing how to open the conversation in a way that leads to a genuine clinical discussion rather than a reflexive reassurance. When you sit down with your surgical team before the procedure, say this: I have been reading about cognitive risks associated with general anesthesia in patients over 70. I would like to discuss whether a regional approach might be appropriate for my specific procedure to reduce the risk of postoperative delirium and cognitive dysfunction. That framing does two things simultaneously. It signals that you are informed and specific, not anxiously vague, but genuinely knowledgeable about the clinical literature. And it opens a real clinical conversation rather than an opportunity for reassurance. If general anesthesia is truly necessary for your procedure, ask why. What specific element of this surgery makes a regional technique insufficient? That is a fair, precise clinical question, and it deserves a fair, precise clinical answer. If what you receive instead is a general statement about routine practice without clinical reasoning behind it, that is the moment to request a direct conversation with the anesthesiologist. The anesthetic plan falls substantially within the anesthesiologist's decision-making authority. A good anesthesiologist who works regularly with elderly patients will often welcome exactly this kind of conversation. They think carefully about these risks. They want to protect you. They may simply need to know that you want to have the discussion because a great many patients never raise it and teams default to established habit. Let me leave you with two real patterns I have witnessed many times across many years of practice. The first is a 78-year-old man, sharp and fully independent, drives himself everywhere, manages all his own affairs, does the newspaper puzzles each morning, and rarely sets them aside unfinished. He has a knee replacement under standard general anesthesia. The surgical result is technically excellent. 3 weeks after the operation, his daughter calls. He became disoriented driving to the pharmacy he has used every month for over a decade. He has no memory of a significant family conversation that took place the previous day. The puzzles are on the table where he left them, started and abandoned, the pen capped beside them. He is not the same man who walked into that operating room. The knee healed. Something else did not come fully back. The second is an 81-year-old woman admitted after a fall with a hip fracture. The repair is performed under spinal anesthesia with light sedation. During the procedure, she speaks with her daughter across the surgical drape. She asks about the grandchildren. She makes a gentle joke about the paper cap on her head. The operation takes under 90 minutes. By the second day, she is walking with a physiotherapist. By the fourth day, she is home. A week later, she calls the clinic to say thank you. She is back in her garden. Her mind is completely clear. I have watched both of these stories unfold in different forms more times than I can count over the course of a long career. And the difference between them, more often than most families ever realize, comes down to a single conversation that either happened or did not happen before the operation began. The surgery protects the body. The right anesthesia protects the mind. And at 70, at 75, at 80, your mind is worth advocating for. Before any surgery, for yourself or for someone you love, write down these 4 options and bring that piece of paper to the preoperative consultation. Peripheral nerve block for procedures involving the limbs and joints. Epidural anesthesia for major abdominal or chest surgery. Spinal anesthesia for procedures below the waist. Conscious sedation with local anesthesia for smaller operations. Write down the question as well. Ask it plainly, with confidence, and with the knowledge that informed patients consistently receive more individualized, more carefully considered care. Not because the medical system is adversarial, but because a patient who asks a specific and knowledgeable question invites a specific and thoughtful response. It changes the dynamic in the room. It moves the conversation from default protocol toward the individual person sitting across the desk. And that shift, quiet and brief as it may seem in the moment, can make all the difference in what life looks like on the other side of that operating room.